So good afternoon, everyone. So today's topic is more of a clinical, less of scientific background, but more and more newer indications of CAR-T. So CAR-T therapy in juvenile onset autoimmune diseases. This was published recently in Nature. Yeah. So as we all know, autoimmune diseases like SLE, juvenile SLE and juvenile dermatomyositis are two prevalent pediatric autoimmune diseases and are characterized by heightened disease activity and earlier organ damage, leading to poor quality of life. And there are significant unmet therapeutic needs and challenges in the management of these diseases. So challenges include often they require combination therapy with prolonged corticosteroid use, and then because of steroid use, there are complications like life-threatening infections and organ damages. And there is limited efficacy of these conventional treatment, even with CD20 therapies like rituximab because of probably ineffective B cell depletion, thereby leading to they barely achieve drug-free remission. So what is the role of B cell in these autoimmune diseases? So B cell play a pivotal role in pathophysiology of all autoimmune diseases by presenting antigens to T cells and thereby secreting pro-inflammatory cytokines, which leads to complications. In juvenile dermatomyositis, B lymphocytes are B lymphocytes significantly reduce Treg cells and expansion and thereby causing expansion of CD19 B lymphocytes. So these abnormalities both in SLE and JDM correlate with clinical severity of the diseases. So targeting B cell is a promising agent either by monoclonal antibodies, which we have already tried and shown inconsistent results. So thereby we can consider CAR-T in these patients. So CAR-T, CD19 CAR-T, it was recently tried in adult patients with just so we have seen many papers from China in which they have used CD19 CAR-T in autoimmune diseases like SLE, dermatomyositis, Sjogren's syndrome, systemic sclerosis, inducing long-term drug-free remission and eliminating autoantibodies by resetting B cell repertoire. So this first was reported in 2024 in pediatric patient with juvenile SLE and dermatomyositis. So as of last year, 2024, only 3 patients were treated with CD19 CAR-T of autoimmune etiology, of which 2 were SLE and one boy with dermatomyositis. All these patients have severe and refractory disease, which was unresponsive to conventional therapies. The median age of infusion was 15 years, and all patients had a severe clinical manifestations. So we'll take patients' detail. So 3 patients were there, 2 of SLE, both were female, both had infusion at 15 years of age. First patient presented with class 4 lupus nephritis, was on dialysis along with other criteria of SLE. The SLE score was 23. They have high dsDNA, high NA, and other antibodies and received multiple lines of treatment. The second patient is also 15-year-old female with autoimmune manifestations in form of anemia, thrombocytopenia, rash with lupus nephritis, lung diseases, pulmonary hypertension, and pericardial effusion with high SLE score, along with positive biomarkers in form of ANA, dsDNA, hypocomplementemia, and high pro-BNP. She also received multiple lines of treatment. And third patient was 12-year-old boy with juvenile dermatomyositis with significant severe muscle weakness, skin rashes, and ulcerations. He also had ANA positivity, along with that positivity for myositis antibodies and elevated interferon gamma. And also received multiple lines of treatment. So what they have included is the immunosuppressive drug should be discontinued before 3 to 7 days, prior 3 to 7 days of apheresis, or on a minimum corticosteroid dose less than 0.5 mg per kg per day. Used FC regimen for lymphodepletion. First patient has lupus nephritis with significant renal impairment, so they use lower doses of flu and Psi. And all these patients received CAR-T dose of 1 into 10 raised to the power 6 to 2.5 into 10 raised to the power 6 second generation lentiviral CD19 CAR. So B cell aplasia was observed in all three patients between day 5 to day 7 post infusion. Complete tissue B cell depletion was confirmed in second and third patient by bone marrow aspirates. First patient had persistent B cell aplasia for 6 months. And third patient had detectable B cells at 8 weeks post infusions. So coming to outcomes, all three patients achieved drug-free remission. First patient is post 6 month post infusion with a score of 0 off dialysis since day 17 with significant improvement in renal functions. Along with that, other manifestations of SLE are better, and she returned to school at 4 months after infusion. Second patient is just 10 weeks post infusion. She also had drug-free period with normal cardiac functions and significant reduction in the antibody titers. Third patient is 8 month post transplant with drug-free remission and regain muscle strength in 4 weeks, along with resolution of the other manifestations of dermatomyositis. All three patients have a manageable side effect. Only one required tocilizumab for CRS management. No ICANS was observed in these patients. Neutropenia was grade 3 in one patient and grade 4 in two patients with grade 2 anemia. So challenges, this is a limited number of patients are included in this paper. Larger cohort and randomized control trials are required for confirmation of the efficacy of CAR-T in autoimmune diseases. Leukapheresis can be challenging because of high disease activity and lymphopenia, either because of disease or because of the drugs. Determining the optimal duration of washout period is crucial for pediatric patients. Exploring reduced conditioning regimen is worthwhile as they have risk of side effects. CAR-T therapy potentially resets B cell compartment and eliminating autoreactive pathogenic B cell clones. And they have observed that seronegative JDM patients have a role of B even without detectable antibodies. So conclude, CAR-T cell therapy is a promising innovative approach for refractory juvenile or adult onset autoimmune diseases. There is a dramatic clinical and biological response observed in initial cases, as we have seen, including the resolution of severe manifestations and drug-free period. Despite promising outcome, further research with large cohorts and longer follow-ups are required to confirm the safety and efficacy, and continued advancement of CAR-T therapy holds significant potential for revolutionizing pediatric rheumatology. Yeah. Thank you.